Yeah, good afternoon. I'll be presenting my paper on hypertensive retinopathy as an ophthalmic clinical biomarker of stroke in Indian subjects. So stroke is the second leading cause of death and a major cause of disability worldwide. Incidence of stroke rises as the population ages, and it has been observed that in low and middle income countries, more and more younger people are affected by stroke. So we aim to study any ophthalmic signs which could easily be observed in the blood vessels of the eye and could be extrapolated to those in the brain and could form a basis of a clinical biomarker for stroke. So we aim to determine a relevant pre-stroke ophthalmic biomarker, the presence of which could be used to predict high risk of stroke event in these subjects in the future. It was a prospective observational hospital-based study. 100 consecutive post-stroke subjects who were stroke survivors were evaluated in 2 tertiary care academic teaching institutions in northern India. A comprehensive anterior and posterior segment evaluation was performed along with any significance of any structural or functional visual parameter which we might find relevant for the occurrence of stroke. Pattern reversal VEP was performed in 83 subjects, and they also answered a translated version of the visual impairment screening assessment questionnaire. So we observed that the average age of subjects in our cohort was 50 plus minus 11 years. Out of these, 83 subjects had ischemic stroke, while 17 had hemorrhagic stroke. The most common systemic comorbidity was essential hypertension in 53 cases, diabetes in 7, combination of hypertension and diabetes in 30, with other rarer causes encompassing the rest. Thus, systemic hypertension in isolation or combination with diabetes was prevalent in 83% of our subjects and was the most common comorbidity associated with stroke. On examination of the fundus of these patients, we found that 34% of these 83 subjects had hypertensive retinopathy. This is one illustrative case whom we observed after surviving the thalamic stroke. He had an up-gaze palsy. On looking at his fundus, the right eye had hypertensive retinopathy changes, grade 2, while the left eye had hemiretinal vein occlusion, which is again a consequence of the raised blood pressure in the patient. He also, due to the stroke, there was an acquired blue-yellow color vision defect and a right-sided hemianopia as seen on the Estemans visual charting. So since in our cohort the average age was 50 years, which is less than the average age of presentation in the Caucasian counterparts, hence evaluation of clinical biomarkers becomes relevant because the patient might not have any other systemic features till then which can warn him of a future risk of stroke. So since it is easy to look into the eye, it is possible to evaluate the vascular changes of the retina, and the similar changes could be extrapolated to other parts of the body including the brain because the ophthalmic and neural event in this milieu is similar. So to conclude, hypertensive retinopathy in isolation does not cause a significant decrease in the central visual acuity in the absence of other associated anterior and posterior segment anomalies. Thus, it is a silent killer of sight. Appropriate evaluation for early hypertensive retinopathy is a relevant ophthalmic biomarker for subsequent stroke in the relatively high risk and younger Indian population. The easily performed ophthalmic procedure of ophthalmoscopy can be used to screen a younger, susceptible and vulnerable Indian population for hypertensive retinopathy, thus obviating many primary as well as recurrent stroke event in them and reducing the morbidity associated. Thank you.
Thank you. That was interesting. You know, I don't know if I'm getting my numbers right, but on an average, if you look at all stroke patients across the board, about 70 to 80%, maybe even 85% would be hypertensive.
Right.
All right. And what is generally the prevalence of hypertensive retinopathy in hypertensive?
So we found 35% of those patients who had hypertension in our cohort had hypertensive retinopathy, and since the screening program for diabetic retinopathy is well advertised and the physician is aware about the need to refer, but in terms of hypertension, the eye examination is really not taken to be done every yearly, or there is no set guidelines for that. So we wanted to highlight that if we look at the changes for hypertensive retinopathy, so it can also indicate that probably the blood pressure needs a better control since the changes can lead to stroke in future.
Right. So, but what would be interesting to note is that 1 in 3 hypertensives has got hypertensive retinopathy,
Right.
and let's say 3 out of 4 stroke patients has got hypertension. So what is the overlap in that Venn diagram? So what percentage of people with hypertensive
So-
retinopathy would go into a stroke as against those who are not having
So in our
hypertensive?
cohort, 24% of patients with stroke had hypertensive retinopathy.
So basically what it essentially meaning is that
1 in
about-
4.
Yeah, 1 in 4. So you would have to look at 4 hypertensives and 1 who was having a retinopathy to prevent a stroke. So that's a very good number for treat.
Also, it would be important to see the grade of hypertensive retinopathy and how many of them had mixed retinopathies, because you said that there was
They were
a subset.
overlapping.
Yes.
Yes.
So, were the patients with mixed retinopathy more likely to develop stroke? And what was the grade? So, an ANOVA kind of test would have been
True.
run on these patients for regarding their age and the multiple comorbidities and gender, and that would have sort of
Maybe we are continuing the study for a
that
larger
would have
sample
added
size.
more information
Yes,
to it.
then probably this analysis would throw up some interesting results.
All the best.